Hello, I'm Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this lecture we will be discussing the urinary system and the act of micturition. This will involve an anatomical dissection of the kidneys, ureters and urinary bladder, and those relevant vessels and nerve supply to them. We will also be taking a look at the pelvic floor and the perineum. So after this lecture and any further study, you should be able to identify the organs within the urinary system, identify the internal features of the kidneys, identify the constriction points along the course of the kidneys, explain the neurological basis of micturition, describe the pelvic floor and the perineum, and describe the innervation of the structures associated with the act of micturition. The kidneys are retroperitoneal organs sitting on the posterior wall of the abdomen either side of the spine. They are sat between the bodies of vertebrae T12 to L3, with the right kidney being slightly more inferior to accommodate the liver. Given their close proximity to the floating ribs, they are at risk of damage, of which we see frequently as a result of road traffic collisions and unlicensed fights or those after a physical altercation. The role of the kidneys is to filter the blood of waste metabolites throughout the system of tubules that rely on osmosis and active and passive diffusion of substances across their cellular membranes. Thankfully, given this is anatomy, we won't be looking at the physiology of these tubules, but we will be looking at the locations within the kidney. We have a collection of fat around the kidneys that helps cushion these fragile and important organs. Additionally, this fat is encased within a fused fascia called garrotter fascia, which helps to isolate infection and metastases. Unfortunately, there are free edges of fascia medially and inferiorly that are not fused, and this is where we will be able to trace the root and spread of infection or a cancer. The kidney itself is covered with a capsule of fibrous tissue called the renal capsule, that also offers some degree of protection from trauma. The external features of the kidney are fairly simple. At the hilum of the kidney, we have the entry point for the renal artery, which leaves the abdominal aorta immediately below the superior mesenteric artery. The right renal artery is longer than the left to account for the left of the midline abdominal aorta and the course of the inferior vena cava getting in the way. Just before the renal artery enters the hilum of the kidney, it divides into anterior and posterior branches that will disperse throughout the kidney. Smaller branches may also come from the renal artery to supply the suprarenal gland. Renal artery stenosis or atherosclerosis is not uncommon and can both have a significant systemic effect, including hypertension and eventual renal failure. Inferior to the renal arteries, the renal veins can be seen draining the kidneys. As expected, one of these veins is longer than the other, but this time it's the other way round. So the left renal vein is longer, as it's had to pass in front of the abdominal aorta to drain into the inferior vena cava. Within the kidney, the renal vein is also made up of 4 or 5 branches as anterior and posterior divisions. Given a large degree in biological variation, we can have an assortment of veins contributing to the renal vein, particularly the left renal vein, often finding a left gonadal artery and the ipsilateral phrenic vein draining from the left gonad and left diaphragm respectively. So don't be surprised if you find in various texts talking about these different arrangements and contributions to the left renal vein. They are quite common and typically don't cause any issue. However, a relatively rare complication of the renal vessel formation is something called a Nutcracker Syndrome. This syndrome, although fairly rare, will help you remember that the renal veins are the vessels passing in front of the aorta, whereas the renal arteries pass behind the inferior vena cava. In Nutcracker Syndrome, the renal vein becomes compressed by the superior mesenteric artery, squashed as though through the vise of a nutcracker. This leads to outflow obstruction of the left renal vein, causing renal vein hypertension and thus hematuria and left flank pain. Given the left gonadal vein frequently contributes to the left renal vein. Nutcracker syndrome can also result in testicular pain or left lower quadrant pain in biological females. We can also see how these long tubes exiting the kidneys. These are the ureters that are travelling inferiorly towards the urinary bladder. These ureters pass anterior to the psoas major and across the common iliac arteries of the pelvis. The ureters contain smooth muscle by which urine is evacuated into the urinary bladder by peristaltic action. The innervation of the ureters comes from 3 different places, but they all amount to the similar principles. The innervation largely comes from the hypogastric plexus, but superiorly the renal and aortic plexus are also involved. And inferiorly we can also receive innervation from the hypogastric nerve. More importantly, sensory information travels to T11 to L2, so patients can present with flank pain, or even as far down as the front of the thigh, from the T11 to L2 dermatomes in the event of ureter spasm. There are 2 sites which we typically find more problems with regards to the ureters. One is up by the hilum, in a junction between the ureter and the renal pelvis, and the other is at a junction where the ureter enters the bladder at a hole called the vesico-urethral orifice. Both of these areas experience narrowing and can become blockage sites for kidney stones. Kidney stones present as renal colic and are fairly common amongst healthcare workers experiencing regular and chronic dehydration, so keep supping that water. Added complications from the obstruction in ureters, whether from kidney stones or ureter stenosis, is what is essentially a backlog of water in a condition called hydronephrosis. In hydronephrosis, we see a swollen kidney on the affected side. Sometimes it can be so large that it is easily palpable during an abdominal exam. If hydronephrosis continues, this can lead to post-renal failure, so intervention is required. So let's have a look at the kidney now. Inside the kidney is where we see all the magic happens. On this coronal view of the kidney innards, we can see these little triangles, which are predictably called pyramids. These pyramids are the location of the long loops of the nephrons called the loops of Henle, that are the functioning units of the kidney. These long loops travel within the pyramids, and through a range of diffusion mechanisms, osmosis, active and passive diffusion, water and waste metabolites are filtered through until they reach the collecting ducts, also located within the pyramids. Once inside the collecting ducts, within the pyramids, they pass into the minor calyx, which drains into the major calyx, and finally the renal pelvis and the ureter, eventually ending in the urinary bladder. But how do these little loops drain fluid? Well, like I said, I won't be going into huge depth because we're stepping away into the realms of physiology, which would require me to dust off my textbooks. So instead, let's just look at the anatomy. Well, remember how we just discussed the renal artery? Well, the renal artery divides when it enters the hilum of the kidney. It divides into anterior and posterior branches called segmental arteries, which in turn divide through into interlobar arteries, arcuate arteries, and eventually into afferent arterioles. These afferent arterioles supply the blood that requires filtering to the glomerulus, which is where multiple stages of diffusion take place. The glomerulus extrudes filtrates into the Bowman's capsule, where it travels through the nephron and being selectively carried forward into the distal convoluted tubule and into the collecting duct. The afferent arteriole drains the filtered blood into the peritubular capillaries, venules, interlobular veins, arcuate veins, interlobar veins, and finally out of the kidney into the renal veins. Chronic hypertension or uncontrolled diabetes can damage these tiny but very important afferent arterioles, and lead to kidney disease and eventually kidney failure, requiring invasive treatment options to sustain life. The urinary bladder is a muscular sac-like organ located in the pelvic cavity behind the pubic bone. Its primary function is to store urine produced by the kidneys until it is ready to be expelled from the body. The wall of the urinary bladder is composed of several layers of detrusor muscle and connective tissue. The inner layer, called the mucosa, is lined with a transitional epithelium which helps prevent the bladder from being damaged by urine. The two vesicouteric orifices and the internal urethral sphincter form a triangle called the trigon. This trigon is filled with stretch receptors that are able to signal when the bladder is at capacity, usually about 400 millilitres. These stretch receptors are ultimately responsible for the urgency to urinate. The urethral sphincter is divided into two parts, each with different innervations. The internal urethral sphincter is under sympathetic and parasympathetic innervation, whilst the external urethral sphincter is under spinal nerve control from the pudendal nerve. A great way to remember the roots of the pudendal nerve is to think S234 keeps the wee off the floor. Voiding urine usually begins with the voluntary relaxation of the external sphincter muscle of the bladder. Parasympathetic impulses induce contractions of the bladder and relaxation of the internal sphincter. Voluntary control of urination is only possible if the neural innervation of the bladder and the urethra is intact. Occasionally, injury and malfunctioning to any of the nerve supplies causes involuntary emptying of the bladder. This involuntary urination is called incontinence. On the other hand, in males, during ejaculation, the closure of the urethral sphincter prevents mixing between urine and semen and a black flow of semen into the bladder. The length of the urethra is different between the biological sexes for obvious reasons. In the biological female, the short journey of the urethra can make biological females more susceptible to UTIs, particularly after vaginal sex. Whereas in biological men, UTIs are less common and should be followed up if they become a regular occurrence. Biological males with frequent UTIs should be investigated for prostate hypertrophy or issues with bladder avoidance, because the longer the length of the urethra is a good preventative for extrinsic pathogens to make their way inside. The perineum and pelvic floor play a huge part in urinary and fecal continence. The pelvic floor, or the pelvic diaphragm, is a group of muscles and connective tissues that form a sling or hammock-like structure in the pelvic region between the pubis and the sacrum. The pelvic floor provides support to the pelvic organs, including the bladder, uterus, rectum, and intestines, and it helps to maintain bladder and bowel control. It is composed of several muscles collectively called the levator ani muscles. These are the pubococcygeus, the iliococcygeus, and the puborectalis muscle. These muscles are also innervated by the pudendal nerve. Contraction of the levator ani muscles also provides additional occlusion to the outlet segments of the pelvic viscera. In other words, the muscles aid in maintaining both urinary and fecal continence until it is convenient to void. The puborectalis muscle best demonstrates this function. Its U-shape that arches around the anorectal junction. When this part of the muscle is contracted, it pulls the anorectal junction anteriorly, forming a 90-degree angle between the rectum and the anus. Therefore, fecal matter cannot flow freely from the rectum. In order for micturition and defecation to occur, the levator ani muscles must be relaxed. The pelvic floor has several openings, including a urethral opening, a vaginal opening, and a rectal opening. These openings allow for the passage of feces, urine, and a baby during vaginal birth. The pelvic floor is important for maintaining bladder and bowel control, sexual function, and supporting the pelvic organs. The perineum is part of the pelvis which contains the external genitalia and anus. It is inferior to the pelvic diaphragm. Regarding the surface anatomy, the perineal area is the region between the thighs, extended from the pubic symphysis anteriorly to the gluteal folds posteriorly. It is divided into two parts, the anterior part and the posterior part. The anterior part is known as the urogenitary triangle and contains the external genitalia. These extend into muscles of the perineum as the bulbospongiosus and the ischiocavernosus. Also present are the transverse perineae that come in both a deep and superficial variety. Collectively, these muscles act to support the pelvic organs, facilitating urination and defecation and playing a role in sexual function. They are all also innervated by the pudendal nerve, which makes it nice and easy to remember. And that brings us to the end of our kidney and urinary system. You should now feel confident in exploring the urinary system as part of your self-directed learning to ensure you're able to tackle the learning objectives for this unit. These are to identify the organs in the urinary system, identify the internal features of the kidneys, and the constriction point along the course of the ureters to the kidneys. Explain the neurological basis of micturition, describe the pelvic floor and perineum, and describe the innervation of the structures associated with the act of micturition.